Thanks for joining us for this presentation, an encore presentation of our MLA Sunrise seminar called VisualDx, Connecting Symptoms to Construct a Diagnosis. Presenting this information today is Patricia Gogniat, Lead Medical Research Librarian, and Kimberly Hamer, Vice President of Customer and Relationship Management. If you do have other questions or concerns, please feel free to use the chat function, and we will get started. Thank you so much. Patricia, take it away.
Hi, thank you for joining, everyone. We're going to talk this afternoon about the diagnostic process. How does a symptom become a diagnosis? Our goal today is to provide you with a foundational background on what a differential diagnosis is, explain the problem of and causes of diagnostic error, and show you how diagnostic decision support tools like VisualDx are one solution to this problem. I'll begin by covering the first portion of this presentation, the history of the problem-oriented medical record and how that transformed into the modern electronic medical record, what SOAP notes are, and how they fit into the ideal diagnostic process. Kimberly will step in to cover the second portion of this presentation, explaining the problem of and causes of diagnostic errors such as biases in medicine, and she'll finish by reviewing how diagnostic decision support tools like VisualDx address the problem of diagnostic error. To begin the story of how a symptom becomes a diagnosis, we'll start with another story, the story of the problem-oriented medical record, commonly abbreviated as POMR, which is the foundation of a solid diagnostic process. This is Dr. Larry Weed, a pioneering physician informaticist who is best known as the creator of the POMR, and later some of the first electronic medical record systems starting in the late 1960s. He's really important to our company because he was a mentor to the VisualDx founder and CEO, Dr. Art Papier. While attending medical school at the University of Vermont in the early 1980s, Dr. Papier was mentored by Dr. Weed. And during his experience interning for and working with Dr. Weed, Dr. Papier became interested in medical informatics and how healthcare technology could transform and improve healthcare. His experience and friendship with Dr. Larry Weed helped lead to the creation of VisualDx 20 years ago. Before Dr. Weed pioneered the POMR, this is what medical records looked like in the 1960s. They were messy, disorganized, handwritten notes. There was no common format or structure, and they were not used as syncing tools like they are today. Dr. Larry Weed began his career as a physician scientist. He studied biochemistry as an undergraduate and went to medical school in the 1940s. After completing a few medical internships, he left medicine for around 5 years to work as a scientist performing genetic research. As a scientist, he was studying one question or problem at a time with a rigorous organized approach, keeping careful records of his research. When he returned to medicine, eventually becoming the director of medical education at a small hospital in Maine, he struggled with the disorganized approach to patient care. His experience conducting research in the lab contrasted greatly against the practice of medicine at the time, which he described as a chaotic system of keeping and organizing data with no systematic review and correction of daily work. In a landmark paper published in the New England Journal in 1968, Dr. Weed proposed the idea of the POMR. As one of the most cited medical informatics papers ever written, Medical Records, A Guide and Teach, introduces the idea of the POMR and SOAP notes. So what is a POMR? It's a method of recording data about the health status of a patient in a problem-solving system. It's a patient-focused approach, which was a revolutionary concept at the time. A primary ambition of the POMR was to create notes where physicians could distinguish relationships between various problems. The SOAP note, standing for Subjective, Objective, Assessment, and Plan, was also introduced in the New England Journal paper. It was developed as a method for providers to document patient encounters in a structured way and provide a cognitive framework for clinical reasoning. Today, SOAP notes are still taught and used. However, the components of a SOAP note eventually served as templates in the development of the first electronic medical record system. Many EMR systems today contain modified features of the SOAP note, such as the admission H&P, history and physical exam note, for ER inpatient record systems. So how do SOAP notes fit into the diagnostic process? In the next slide, I'm going to cover each component of the SOAP note. The subjective portion of a SOAP note is comprised of information from the patient. When a patient experiences a problem or some type of symptom, what brings them into the doctor's office is known as the chief complaint. The patient is usually asked a series of questions regarding the chief complaint. For example, an 18-year-old female presents at the ER with severe abdominal pain. She is asked many questions about the chief complaint. When did it start? Where exactly does it hurt? What is the quality of the pain? Is it crampy? Is it stabbing? Does anything make it better or worse? The patient fills out medical history forms and is asked further questions about any other symptoms, along with her social history, medical history, and family history. In our example of the 18-year-old with abdominal pain, subjective notes include 18-year-old presents with 24 hours of worsening abdominal pain. Patient complains of severe lower abdominal pain, worse with movement, nausea, and loss of appetite, but denies vomiting or diarrhea. Patient is sexually active and taking oral contraceptives, has a family history of heart disease. The objective section of a SOAP note documents information from the provider perspective and includes data gathered during the physical exam, lab tests, and from imaging tests. It's important to distinguish here the difference between a symptom and a sign. A symptom is experienced by the patient and is subjective information. A sign is observed or measured by the healthcare provider and is objective information. For example, abdominal pain is a symptom, but abdominal tenderness is a sign. It is observed by the provider when the provider presses on the abdomen of the patient and the patient flinches and experiences pain. In our example of a female presenting to the ER with abdominal pain, her vital signs could indicate tachycardia, mild hypertension, and a low-grade fever. The physical exam could indicate right lower quadrant guarding and rebound tenderness, and slightly hypoactive bowel sounds. In an ER setting, due to her age and the chief complaint of abdominal pain, a pregnancy test would likely be ordered right away to quickly rule out ectopic pregnancy as a cause of the abdominal pain. The assessment portion of the SOAP note is where the provider documents their thinking process regarding what the diagnosis is. This is the heart of the diagnostic process, though all steps are equally important in minimizing diagnostic error. We'll talk more about that later in the presentation. In the assessment note, the subjective information from the patient is combined with the objective information from the provider to come up with a list of diagnostic possibilities known as the differential diagnosis. The provider writes a brief summary of the patient problem, then lists the diagnostic possibilities ordered by most likely to least likely. Before continuing on, I'd like to review some basic terminology with you. What is a medical diagnosis? It's actually a somewhat confusing term because it is usually used as a synonym of a disease or condition in the context of the diagnosis of asthma is represented by wheezing and shortness of breath. But actually, the dictionary definition of diagnosis from Merriam-Webster is the art or act of identifying a disease from its signs and symptoms. For example, she is an expert in the diagnosis and treatment of eye diseases. A differential diagnosis is a list of potential diagnoses or the distinguishing of a disease or condition from others presenting with similar signs and symptoms, commonly abbreviated as DDX. A differential looks at the possible disorders that could be causing your symptoms. At VisualDx, we talk about the importance of building a solid differential diagnosis, and providers use our resource during the assessment portion of the SOAP note. Kimberly is going to talk more about some of the causes of diagnostic errors, but doctors need help remembering all of the diagnostic possibilities, and this is where a tool like VisualDx or other diagnostic decision support tools can be used to reduce diagnostic errors. Based on our case of the 18-year-old female with abdominal pain, here's a screenshot of what diagnoses a clinician might be considering based on her signs and symptoms. Acute appendicitis, as you know, is at the top of the differential list. The plan portion of the SOAP note focuses on what to do next based on the assessment note and a list of probable diagnoses. Order more tests or referral, or if the diagnosis is confirmed, come up with a treatment plan or schedule a procedure and education plan. Based upon our case of an 18-year-old female with abdominal pain, here's what case information could be included in a SOAP note. This is a story from the medical provider's perspective of how a chief complaint of abdominal pain becomes the diagnosis of acute appendicitis. Subjective information. Patient has severe lower abdominal pain, worse with movement, began and worsened within 24 hours. There is nausea and loss of appetite, but the patient denies vomiting, diarrhea. Patient is sexually active, on oral contraceptives, and has a family history of heart disease. Objective information is it's an 18-year-old female. Her vital signs indicate low-grade fever, mild tachycardia, and hypertension. Physical exam indicates right lower quadrant guarding and rebound tenderness. She has slightly hypoactive bowel sounds. During the assessment note, the provider would put together the subjective and objective information to write something like 18-year-old female with acute onset of severe abdominal pain, positive for rebound and voluntary guarding and RLQ. Labs are normal, urinalysis is normal. And then in the bottom portion here in the assessment box, you'll see they typically write out the list of probable diagnoses with the most likely being at the top, and they'll write notes ruling in or out some of the other diagnoses. So in this case, ectopic pregnancy really fits the pattern here, but the doctor thinks it's less likely because the patient is on oral contraceptives. A small bowel obstruction is less likely because the patient's not experiencing any vomiting, and with that condition, you'd likely see vomiting. The plan note here shows what lab tests would be ordered. So if the doctor is thinking that the patient has appendicitis, they'd likely order a CT or possibly a pelvic ultrasound. The SOAP note appears like a linear process, but really it looks more like this. The SOAP information is in the circle in the middle, so you see that patient experiences a health problem, engages with the system, they come in with their chief complaint, and the information that's gathered by the provider is, you don't receive all the information at once. It's likely that in this scenario, the patient would have gotten a pregnancy test right away to quickly rule out ectopic pregnancy. The CT would be ordered. If that was negative, they would kind of cycle back. You'll see that they have a working diagnosis based on the presenting signs and symptoms, and would order lab tests to rule in or out the other diagnoses within the differential. What's really important about this diagram is that outcomes should be measured. So there isn't a great feedback loop right now in the system, and this diagram comes from a book called Improving Diagnosis in Healthcare, which is published from the National Academies of Sciences, Engineering, and Medicine. They really recommend that when there are diagnostic errors, they are increasingly captured and analyzed. What I've shown you is the ideal diagnostic process, but there are shocking statistics around the incidence of diagnostic error. EHRs, while designed around the POMR concept, are to most physicians considered a glorified typewriter, and there are still many problems with executing the ideal diagnostic process. We're going to show you a video featuring Dr. Larry Weed, which highlights these problems, and then Kimberly is going to continue and talk to you more about the specific pitfalls in the process and how clinical diagnostic decision support can help improve the process and reduce diagnostic errors.
The attending physician took the notes from our doctor, but he said in no uncertain terms that he was going to make his own conclusions. Thank you very much.
I mean, they keep on talking about, well, clinically he looked like that and clinically he looked like that, so we didn't have to do X, Y, and Z. At the end of the day, someone dropped the ball, and unfortunately it was with our son.
The doctor has to be a guidance system. He is not an oracle that knows answers.
Maybe there's something wrong with the way we're running the whole operation. Memorize, regurgitate, forget. Memorize, regurgitate, forget.
There's 500,000 deaths a year from mistakes in medicine. Where's the outrage? In every other field, they extended the hands and the eyes with instruments. That's why in the 1950s, when the computer came along, scientists who were trying to get a rocket to the moon said, we can't do it. We'd have to solve this many differential equations at the speed of light. We can't do it. That machine can do it. Now we can do it. Well, why didn't medicine? Because we thought we could move knowledge from the books and laboratories to the patient through the heads of human beings.
The human mind can be encouraged to press its limits, to challenge, to question, to search. But then the general practitioner is actually faced with complex problems that require creative solutions all the time.
We as humans have only this much capacity for facts. And the number of facts got larger than fits in this box called our brain. And the number of diagnostic errors increased dramatically.
Of course we have all these mistakes. And it's not the doctor's fault. We don't have a system.
Traditionally, to learn about a problem diagnosis, doctors went and looked in a book. Last 10 years, they went online, but they're essentially still looking at a book.
But supposing you said to a pilot, you look in the cockpit, do you know what all those instruments are on the dashboard? Well, most of them. Some of them I don't. But we get there most of the time.
Society could, if it were aware of the problem, change it virtually overnight.
When I keep thinking, my God, I was born in 1923. I've been screwing around. We got to get something done. So I finally came to the conclusion, your generation has to do it.
We're going to do it.
You got to do it.
Hi, everyone. This is Kimberly. So you heard Dr. Larry Weed, who said our generation has to do it. I want to share something. So about 4 years ago, there was a published study from the Institute of Medicine where they said, quote, nearly every person will experience a diagnostic error in their lifetime, end quote. Nearly every person. That means either those of you on the call, you've already experienced a diagnostic error, or you are aware of someone who has. And a lot of times, if you say to someone, oh my gosh, something terrible happened, medically, most people just assume that they were given the wrong medication or something terrible happened in surgery. But as this slide demonstrates, that's just the tip of the iceberg. That is not what causes most of the errors. Most of it really lies with diagnostic errors. 74,000 Americans die every year as a result of this. 18 million times a diagnostic error is made. Isn't that alarming? I can't see you guys, but I'm assuming you're all going, oh my gosh, that's alarming. Because it is. Moving on to the next slide. One of the things we always wonder is, well, how on earth does that happen? Why would that many diagnostic errors happen? It's really, like Dr. Weed said, not a fault of the physician, but really the process. What you're looking at right now is a way to represent what a physician's day looks like. On average, they see about 20 patients, and they sort of queued up, like this slide represents, the line of people. They're not all waiting in that way, but the function is the same. So let's say the physician starts his day with someone who's coming in and his main complaint is a rash. He sees them, he asks the right questions, he diagnoses, and he moves on. And that goes that way for the rest of the day. But the fourth or fifth person, if you can see by the slide, one gentleman came in complaining of a headache. And it turns out he was diagnosed with a tension headache, but what the physician didn't realize was that that patient had actually been exposed to carbon monoxide as part of his work day. And so there was a premature closure there where he diagnosed him with tension headache. So off that patient goes again. Now here's the physician seeing another person, and all those he gets correctly. And then later in the day, he sees this young lady, and she mainly complains about dizziness. Diagnoses her with benign positional vertigo. Turns out she's actually having the form of a stroke. He anchored on the main complaint that she had, which was dizziness, and he went from there. Again, given the day that he's had and all the people that he's seen, and the main thing here is that most of what he's seeing are common and repetitive symptoms, that's what a typical day looks like. So how does that happen? I'm not sure how many of you are actually familiar with a book called Thinking Fast and Slow. What that book really talks about are a few different things. One is, how is it that clinicians do misdiagnose? Some of it happens because they're prematurely closed, like we previously talked about in the example just now. Some of them anchor on what the chief complaint is from the patient. Some are just overly confident. That's just human nature as well, and there are a variety of reasons. Some of it, though, really lies with what we call representative bias, and that is where a lot of the classic symptoms, they just look the same and sound the same, so they're diagnosed the same, but sometimes they're actually hiding something completely different. So it's a variant of the common. And a lot of times that's the pitfall of the poor clinician. So representative bias, I know there are 3 examples on this slide, but for the sake of time, one of the ones that always jumps out to us is we had one of our users write in and shared that a few years ago, a 57-year-old gentleman walked into an ED in America and said, you know, I've got a toothache and I've been extremely tired. He was triaged by the nurse. She assumed that he wasn't in any dire straits, and she put him back in the waiting room for a few hours. Turns out that patient was actually having a heart attack. Again, 2 simple symptoms, easily missed as something very, very simple, but it was actually hiding something that was way more severe. So that sort of representative bias is what also leads a lot of times to a misdiagnosis. Another thing that's referenced in the book Thinking Fast and Slow is something called the Echo Principle. Really what it is a trade-off between efficiency and thoroughness, right? So on one end of that spectrum, if you're crazily thorough, then you have less likelihood of making errors, but your efficiency is also really, really low, and you're also moving very slowly. On the completely opposite end of that spectrum is a level of efficiency where if you're really, really efficient, you're moving fast, but you also have a penchant for making more errors, and you're not as thorough as you would have liked to be. In our current state, I know we're in a transitioning state right now, but for the fee-for-service sort of approach, this has been a challenge within the U.S. for quite a while. How do you balance this? The hope is that with the change to value-based payment, or VBP, that there'll be a healthier balance here, because now physicians are more inclined to be focused on quality as opposed to quantity, and that will help balance out this Echo Principle a little bit better. So we're all going to keep an eye on that and look to see how that plays out. The next slide is actually one of my favorite ones. So Coverys is one of the leading risk management companies in the U.S. They have a new name now called MedIQ. Some of you may know them by that. But they published a study last year where they had looked at the claims that stem from malpractice. And as a result of their evaluations, they found that 33% of the time, it was a diagnosis-related error. It wasn't medication. It wasn't a medical mismanagement. It wasn't something in surgery. It wasn't a procedure. It was a diagnostic error. If you look at the upper right-hand side of that slide, 53% of the time, that error happened because of poor clinical decision-making. And 33% of the time, that poor clinical decision-making actually happened during the time when they were evaluating the patient. So the lower part of this slide also gives a couple other quick tidbits from Coverys, where they said that 36% of the time, these claims stem from either an outpatient location, or 24% of the time they were in the ED or in an urgent care kind of facility. As a result of that, one of the things that Coverys does is for their subscribers who pay for malpractice insurance, they give them a discount. They have an option to get a discount if they use VisualDx. They get a little bit of a discount off of their premiums, because from Coverys' perspective, this is a big bit of exposure for them, and they know that a tool like ours helps mitigate that. So as a result of it, in the lower right-hand corner, they call out 3 things. One, clinicians really should use the technology and decision support tools made available to them, because it's only fair to them. It's not fair for all of us to expect, like Dr. Larry Reed said, that clinicians are expected to hold everything in their head. Our CEO likes to use an example where he sort of has this equation of, the brain plus the computer is always greater than the brain alone. And that also stems from some of what Larry Reed shared. Coverys also recommends that uncertainty be documented in the EHR. Historically that was taboo. If there's anything that was uncertain, you don't say it. You sort of just think it and you move on. But he really encourages that you document that, because at the end of the day, you don't want to misdiagnose the patient. And communication is key. That's the last part of the recommendation. Putting information in the EHR, putting all the information in the EHR, good, bad, and ugly, is always to their advantage. So there's always some cost associated with this, right? So Each year, 500,000 Americans are admitted into the hospital system for just one diagnosis, cellulitis. Just that one, 500,000. 20% of those people don't have cellulitis. 20% of those people don't have cellulitis. That costs us about $12,000 per person, and overall in the industry, about $1 billion. But you know what? The thing that really worries us is the fact that those 20% are being given meds and being treated for something that they don't have. We're increasing harm for them, and that's alarming for us. So that's some of the reason why we so love being able to put an application like this in the hands of clinicians to help them, because we know that their goal is the same as ours. So we're curious, and please feel free to use your chat function at this point, but what do you think physicians tend to use when they get to a point in their process where they're not sure what a patient may have? We're just looking for some quick feedback from you guys. We'll pause for a moment just to see what we get on the chat. What do you think they tend to do? All right, thank you, Penny. You're thinking they go to other MDs. Got it. Consult a product like UpToDate. Got it. Thank you, Michael. We'll take another one. All right, here's the big reveal. Here's what we've learned, not only from our medical librarians across the U.S., some of them have published some posters that reference this, and we've also had some other international studies done around this, but here's what happens. They tend to use what we call Dr. Google, because the clinician knows that they need some help, and so their intent is to help the patient, so they go to whatever resource they feel is quickest and easiest and fastest and most accurate for them, but a lot of them go here. So, according to Dr. Larry Weed, this is what, pilots in the cockpit have a lot of tools. I think if any one of us walked onto a plane, turned to the left and saw a cockpit that looked like this, we'd most likely do an about face and get right back off. This is really concerning to us, right? That if any one of us thought this was the way this was going to go, it wouldn't fly. So given that, why do clinicians, why would a clinician feel a need to use Google? Because tools are designed for specific tasks, and why wouldn't they use something that's helpful to them? So some of what our belief is, truly, is that it's a matter of skin in the game, right? So for the pilot, should they use that Google Cockpit? If anything goes wrong, whatever happens to their passengers happens to them. So skin in the game is in full force with the pilot. Compared to a clinician, like we just referenced on the Coverys report, a lot of times those diagnostic errors occur in an outpatient setting. So you're not going and seeing your regular PCP, you're going to a physician that you don't really know. So you go in, you tell them what's wrong, they diagnose you, you walk away, you follow their treatment plan, and let's say it doesn't work. You may go back to that ED or that outpatient clinic, but you may not see the same physician, or you may go to your own PCP. But now that initial physician that diagnosed you isn't aware that happened, so there's no closed loop process at all there for that physician. There's way less skin in the game for him or her compared to the pilot. And for us, we think that's what makes one of the biggest difference. So we're in complete agreement with Dr. Larry Weed, that this is a big deal. So our intention is that VisualDx becomes a sort of guided cockpit for the clinician. Our medical terminology is standards-based. We have over 41,000 medical images in a variety of forms, and you can see different methodologies in there. We also have a really comprehensive medical knowledge database. We have a slew of medical librarians. Patricia is our lead one. We have an editorial staff. We have a visual search process and interface that is like no other. We refine and we use things like machine learning and augmented information to help. We put all those things together in an attempt to deliver meaningful answers to a clinician within seconds. That's the idea. Our product does not work without the clinician's clinical judgment. It just doesn't function without it. It's meant to provide help to them. This is an example of sort of the difference, right? So in the upper left, it shows a list of text. Just think as a busy clinician, you're trying to hold some of this information in your head and try to compare it with something else. Compared to our image, which is in the center of the screen, it's way easier for the human brain to process quickly images. So that's why we promote it this way. We reduce the cognitive burden for the clinician. It just makes it way less complex for them. We also support the recognition of how a disease is presented from the standpoint of variation. So in this case, it's an example of Lyme disease. You put certain findings into our application, and then it shows you how the morphology of that sort of changes over time. So what's the value from our end? From our perspective, diagnostic accuracy, that's the big deal. That's what the Institute of Medicine says we're in a medical crisis about, so that's our focus. Our goal is to aid with therapeutic decisions and to improve patient care ultimately. We don't want those 20% being admitted to hospitals with the wrong diagnosis and being given pretty much drugs and medicine that's not good for them. So the idea is to build a custom differential diagnosis that's based on a chief complaint, and we're across all medicine. We're not just derm-based. You can search for a disease, you can search by disease for therapy options. We give you examples for tests and therapies and management pearls. The other nice thing too is you can also put medication information in there, and it will give you some feedback from a differential with regard to any adverse drug events that may occur because of that. If your patient had traveled to some region of the world, you can put that information in there, and it will give you part of your differential that reflects the region of the world that your patient was in. This is what we do. This is the value that we provide. So if you were to look at this big circle, the center of it is the crux of who we are, our VisualDx platform. The items to the left speak to the tools that we are able to help the clinician with and we arm them with. The items to the right are what we use to arm consumers. So let's start with the items on the left. At the top is the basic flagship product, our VisualDx product. The one right beneath it is called DermExpert. This we launched a couple of years ago, and essentially what DermExpert allows the clinician to do is to use their phone to take a picture of something that the patient is presenting with. Then from there, AI and machine learning technology analyzes that image to help determine what the correct lesion type is. Then the clinician uses that, puts in any additional findings that are relevant, and comes up with a differential that they then use their clinical judgment to refine and decide what the actual diagnosis is for that patient. So DermExpert is very, very popular. It's easy to use, point of care focused, and so we have a lot of pride in the fact that we produce that. The one beneath it is called LearnDerm. LearnDerm is primarily an educational resource. We are in over 50% of the schools of medicine across the U.S., and this can be used either as a form of self-study online, or there's also a sort of pocket reference that students and residents love to use to keep them in their laptop, the pocket of their lab coat. So that's another really popular one. On the right side of the circle speaks to two. I'll start at the bottom with SkinSight. So SkinSight is actually a product that we've had for a few years now. It really is a free online reference for people to go to and learn information as it relates to anything related to dermatology. The last but not least is ASA at the top right. ASA was launched within the past year. This is for the non-clinician. The one call to action I have for all of you who are on the call today is to please go either to your iOS store or your Android store and download ASA. It is currently free. It will not remain free. But the idea is it allows the non-clinician to take a picture of what's presenting on the skin, answer 2 or 3 really basic questions around, does it itch? What size is it? How long have you had it? And then it provides you with some options for either self-care. We, of course, always encourage you to go to your doctor, but now you can have a more meaningful conversation with your doctor about what you think you may have. And then you also have some options for self-care and treatment. Maybe it's just a matter of using some Benadryl until the morning when you see the doctor or something along those lines. This is a visual example of how DermExpert works on the phone. So first you just have a picture. It confirms the lesion type. You add any other symptoms or findings, and then you review the diagnostic possibilities from there. The next slide speaks to ASA, which works very similarly. You take a photo, you answer some questions, you review it, you see the results, and you decide what action you want to take. You find a doctor, you can partner up in a telemedicine program, or you can just be linked out to a local retail store to buy something topical to help yourself in the moment. So that we just wanted to make sure you had some visual aids based on what I was sharing. So now that being said, Patricia has taken you through sort of the history of how it starts the symptom and ends with a diagnosis. The wonderful work of Dr. Larry Reed, we have a lot of respect for, and the creator of the SOAP note. She described what the SOAP note is, some definitions around diagnosis and differentials. We've also talked to you about the state of the U.S. today and how diagnostic accuracy plays such a huge role in it, and how a product like VisualDx or something similar can help the clinician do what they intend to do, which is to do great work by way of that patient. So that being said, we're expecting that you guys probably have a few questions for us. We are anxiously looking forward to answer those for you. So please let us know what you have. Thank you. All right, so we're going to assume that because it was so entirely thorough that there are no questions, which we love. This video will be made available, but I'm going to tee it back over to Kim to close us out. Thank you all again, though, for your time and attention.
Thank you so much to Kimberly and to Patricia today, and to all of you for joining us. Again, as Kimberly mentioned, this is being recorded. We will be emailing you a copy of it. Feel free to share it with your colleagues, and feel free to reach out anytime if you have any other questions or concerns. We really pride ourselves in customer service here. So thanks again for taking the time on this Wednesday afternoon, and appreciate it. Have a great day, everyone.